Welcome back, lovely listeners, to the Sports Medicine Project, and welcome to Part 1, Knee and Shoulder Orthopaedic Surgeon Dr. Jai Kumar, talking all about ACLs in this episode. Welcome to my co-host, Kelly. How you doing?
I'm good. I'm always good.
Yeah, can't be much
Sunday
better after
morning.
listening to this.
Sunday lunchtime it is right now.
Lunchtime now. That's okay. I mean, this episode, what do you think? One of the... Could be top.
Always.
They're always number one.
I do tend to say that about every episode.
Yeah, but we've got that sunk cost fallacy because we record it. We have to say it's good, but we do think it's good.
But this one's real good.
Yeah, you know when you buy, it's like, yeah, it's good. It's good, but it was awesome. I mean
it this time.
Yeah. The last 9 episodes, I didn't mean it. This episode, I mean it.
This is the one.
But to have the ability to talk to someone with that amount of knowledge and nuance, talking about, ACL bracing, surgery versus conservative, risk factors, what the surgery involves, what to look for in a scan, what scans to get, screening for ACL, the importance of physio, rehab, it was...
What role does podiatry play in ACL management?
Nothing. And if there's any podiatrists out there... No, I did post a study on LinkedIn a while back that was looking at stability shoes versus neutral shoes, and they looked at the torsional rotation in the knee and found that it was less, like the peak was less and the overall was less in stability shoes. So they hypothesized maybe, and they're talking about this in football boots and in joggers, that perhaps maybe footwear could play a role in reducing the risk of ACL if we understand the mechanism, and shoes could reduce that. But again, that's a very big leap, and no way in hell am I about to be telling people that wear these shoes for your ACL injury. The podiatry doesn't play much at all. I just love to hear this stuff. Like, it's awesome. I mean, I follow so many people that talk about ACLs. I mean, you manage them all the time, but I just love to sit there and just be in awe and listen to people talk about the human body. It's great. And then to share this with our listeners. I mean, how lucky are we, and how thankful we are to Dr. Kumar for donating his time between patients and so much other stuff that involves being an orthopaedic surgeon. I mean, yeah, we're just incredibly grateful and feel pretty happy that our listeners are gonna love it.
Yeah.
Or their listeners. Yeah, not our listeners. Their listeners are gonna love it.
The lovely listeners.
Yeah, the lovely listeners.
Our favourite people.
Yeah. I think it's gonna be good. I thought that we were gonna have this in one part, but we spoke for I think it's about 89 to 90 minutes. So we're going to put it in 2 parts and not have too much yarn at the beginning now, and just get straight into it. Yeah. Was there anything that you can remember that you think that was...
I really appreciated Jai Kumar's opinions on the cross-bracing protocol. I think that was really useful to get that voice out there from an orthopaedic surgeon, because that's being thrown around a lot at the moment, and it is new and we don't know a lot about it. So I appreciated his opinion, and it was very nuanced, as we sort of said before. So I think that was a highlight for me.
My highlight, which is, I know you're going to be annoyed, it was when you had to run, but I got to stay on and talk about just the steps involved in the actual surgery. Like, that is just... It was awesome. I dreamt of ACLs that night, even though I'm never going to see one in my life. But just to hear the steps and what goes through it, and it does sound pretty simple the way they explain it. But just to imagine seeing inside the knee and then the repercussions that's going to have for someone's life, like it's pretty awesome.
Did you feel triggered at all talking about ACLs? Does it make you think about your knee?
No, not really. I mean, I think that I know enough to be confident in the body's ability to adapt and be strong, and perhaps I think you and Nikki's put the put the demons in my mind when you told me I'm going to need a knee replacement at 29 because I don't have an ACL. But
you don't have an ACL plus some other things.
Plus some meniscus and stuff like that. Maybe I should post a scan on the Instagram as
get some opinions.
Case study. Hey, what do you think? Hip replacement, knee replacement? What do you think? Limb length difference? Whatever. But it was just interesting to, like, I think if I had understood it more back then, I probably would have had the surgery, but I don't have any issues now. But it was, just hearing what steps are involved, and it makes me, and I think this every time we speak with a guest, where we talk about things in such a simplistic way, which is fine because that's an easier to understand, and there's certain levels of knowledge. As you get to an expert, you can talk about it, with high detail. But these things just aren't as simple as like drill here, drill there, ACL to there. You're fine. You're good to go. Like there's so much more involved in it, and that's why we do this podcast, to present information about sports medicine topics and talk to sports medicine specialists like Dr. Jai Kumar or Dr. Richard Willey, Dr. Ebony Rio, Dr. Stephen Kent, like these people that really understand it that high detail, and then can bring it down for us and make it a bit more simplistic, which was awesome. Yeah.
Absolutely. Yeah.
So enjoy, guys. We'll speak to you all next week.
So thank you so much for joining us, Jai. It's been a long time coming, a few emails back and forth over the last few months.
That's my fault. I'm so sorry.
No, totally understandable. We're stoked that we could make the time to tee this conversation up, and we are really keen to pick your brain about all things ACL, injury and surgery and non-surgery options. So thanks for joining us.
No worries, it's my pleasure.
Yeah, that's awesome. I mean, we're talking, Kelly and I were speaking about this morning, you see so much stuff on social media and you read research and hear all these things, but it's generally from, physios or other clinicians, and just the opportunity to speak to someone that's actually doing the surgery and understands everything that goes with it and all the nuances as well. It's awesome. So I know everyone's going to love it. So it's going to be great.
I'm glad to hear.
And so how did you find a bit of a niche in, and you're a knee and knee and shoulder orthopedic surgeon. How did you make your way down that pathway?
Yeah, so I mean, I was born and bred in Newcastle. My dad's a GP. He's 82 this year and still working part-time. And despite me trying to convince him otherwise, he continues to work. So I grew up in a medical family where looking after people and healthcare was always part of what we did as a family. Like, we were one of those families that the doctor's phone number was in the white pages. So patients would ring you up on your landline and ask to speak to Dr. Kumar, and he'd go out early in the morning, so at middle of the night. So I grew up in that kind of household, and I guess you're conditioned by the environment you grow up in. As I got through high school, I did a lot of sport and played a lot of sport, and loved the way the human body moved, and loved the concept of people trying to be the best versions of themselves. And once I got through medical school, it became clear that orthopedic surgery we had the privilege of working in a specialty where people get better a lot. And a lot of my colleagues work very hard and put a lot of time into people that unfortunately don't get better. And I always liked the concept of fixing someone and seeing them get better and return to what they wanted to do. And that really appealed to me. And that's a little bit selfish, I guess, in some ways, but I just enjoyed that. And a natural flow on from playing sport and being active is, I guess, heading into that kind of area. And for me, sports injuries were really personified by largely shoulder and knee injuries. They're a high volume of what we see. There are elbow injuries, there are ankle injuries, all those kind of things. But I really lent towards sports surgery, and my time overseas on fellowship was looking after the management of high-level athletes for most of the time.
Yeah, wow. And like ACL surgery, I'm sure that's evolved quite a lot. I mean, it seems like it's already evolving just in, our careers or the last sort of 5 years, and with different sort of protocols and methods that are coming into play, which I'm sure we'll talk about a bit later on, such as like the cross bracing protocol and things like that. But
we're seeing patients now in their 50s and 60s that have come back with post-traumatic arthritis after having what was an ACL reconstruction 30, 40 years ago. And when you hear about their operation, they had some kind of ligament reconstruction. When you see the x-rays, you think, oh, what have they actually done there? I'm not quite sure how they've reconstructed that. But these patients were in full leg casts for 6 weeks and often in hospital for 6 weeks.
Wow.
And now ACL surgery is a day procedure. People walk in and walk out the same day. So the is extraordinary. And as you know, in medical technology, things evolve almost on a monthly basis. If you're doing the same kind of stuff you did 10 years ago, you're behind the 8 ball.
Is it true? And I've heard this from some other orthopedic surgeons, like the confidence that you have in doing the surgery plays into it as well. Like, I think from a clinician standpoint, people say, if things are evolving and the research is evolving, you can't always keep up with it. Like you said, if it's changing month to month, and it comes down to what that person is most confident doing surgically. Is that right? Or does that have much weight to it?
No, you're exactly right. So, I mean, we do know that the surgeons that do higher volumes of the same procedure generally tend to get better outcomes. And I think a lot of that's to do with reducing variables in the surgical process and the rehabilitation process. So, a lot of surgeons by nature are quite OCD, obsessive kind of personalities, and we like control over our situations. And if we can control the variables of the surgical journey from preoperatively through the surgery all the way through, say, return to sport, if you can keep patients in the middle of a tight bell curve, the reliability of achieving the outcome required is significantly higher.
Yeah.
And so, the very good surgeons I've worked with can put their operations down to a number of steps. So they'll say a knee replacement takes me 87 steps. An ACL takes me this many steps. If I miss that step, or I do that step before that step, or it's out of kilter, then that creates a variable which has the potential to derail an outcome. So, which sounds very boring. And it's funny when you talk to patients, they go, I just want, I want you to do the absolute best you can to give me the best outcome. And actually what you want to do is give people a boring, reliable outcome, because define what the likely endpoint is going to be for them.
Yeah. Do you find it difficult? I mean, maybe like in the last kind of 5 to 10 years, seeing all this stuff, coming out about complex system theories and people being so unique and variable, and we can't control biomechanics and anatomy because people are so different and respond differently. Do you find that difficult with patients? Because it is really anatomical and biomechanical what you're doing, and then trying to, I guess, get in the long term. But do you find that challenging when you're just dealing with individuals and people that respond so differently to the same thing?
I don't find it challenging. I find it more fascinating, because I think the moment we treat patients like a machine, or a joint like a hinge, or whatever it may be, we start to lose sight of I think the art of being clinicians, whether you're a surgeon or a physician or a physio or an EP or a podiatrist. We're learning so much, especially more recently, about not only the physicality of injuries, but the psychology of injuries. And so to manage an ACL, for example, it's not just rebuilding a ligament. It's recognizing the ligament attached to the knee, attached to the leg, attached to the human, attached to the brain, attached to the social network that they're involved in, attached to their vocational pursuits, their recreational ideologies. So when you look at it from a broader perspective, you realize that we've actually been working with human variables for a long time. We just more recognize it now than what we did back in the past. And I think that's where our outcomes have probably got better, because our approach to every patient has to be different, because every human being is different. And it's not just the biomechanics or the anatomy, it's the personality of the individual.
That's so refreshing to hear. That's awesome. That's really cool.
How do you take some of those different variables and factors into consideration when you're, assessing and managing different people sitting in front of you?
Yeah, so first thing I always think about is the human being before the injury, and what their functional expectations are. And that drives, coming back to ACL surgery specifically, it drives your decision-making process about what you're going to do for that patient. Because the sad reality for surgeons is you can teach a monkey or a robot to do an ACL reconstruction, but what you can't teach that person to do is to understand each individual's specific functional requirements. So, a 40-year-old weekend warrior that busts their ACL, after coming back from having a family and kids and trying to get back into touch footy on a weekend, is very different to an elite collision athlete that wants to get back and their rugby league career, for example, is going to be their long-term future. So I think for me personally, a lot of it before you do anything is actually having a discussion with a patient about where they're heading, and where they want to be in the next 5 or 10 years. Because if I often say to patients, the best operation you can have is one that you don't have. And a lot of patients that come to you with pathology often find it hard to understand that you're going to send them home without an operation. But when you put it in the context of their life and what it means, and the risks and benefits and the impact on their family and all those kind of things, often it makes sense.
Yeah, no, that makes total sense. And like, especially in the physio world at the moment, there is a lot more conversation going on around the non-surgical options for ACL management. And, my understanding is that that's possible when it's an ACL in isolation, but maybe not so much when there is a meniscus involved, or if they are a younger athlete and want to be returning to sport because it's potentially going to risk a meniscus injury down the track. But can you speak to a little bit to that?
Absolutely. So, I mean, the non-operative management of ACLs has been around for a very, very long time. It's something that has always been part of my practice and a lot of surgeons' practices. I think it's gained probably a lot more momentum recently because obviously we've got the cross-bracing protocol. We've got, I guess, the recognition that we can, with appropriate functional rehabilitation, patients can get back a degree of functional stability. I think the reality is that where the management of non-operative ACLs has to be done appropriately and with, I guess, a clear understanding to the patient about what the risk-benefit ratio is to that. So, I mean, if I'm 44 and I'm a dad of 2 and I like to stay active, but I'm not pivoting anymore. And for me to have an ACL reconstruction is a big deal to my surgical career, my staff, my family. And so from my point of view, I would think, well, with appropriate rehabilitation, I'm not going to get back to where I was before my ACL rupture. But if I modify my expectations, I should be able to make it fit. So what I often say to patients is every patient that comes into the room has functional expectations that are higher than their reality. And that's why they're there to see you. And what we do is we walk through the non-operative options and see how much better non-operative management can make their reality. And often the reality doesn't quite hit where expectations are. If a patient's willing to slightly modify or alter their expectations and make it meet with their reality, then they're done. If they're unwilling to accept that difference, that's when surgery comes into it. Now, probably the challenge with non-operative management of ACLs as an ACL surgeon is when you see the patient that has gone down the non-operative pathway but hasn't been made aware of what the risks are of doing that. And the challenge for us as medical professionals is if we get these patients late and let's say John Smith, call him John Smith, has a rupture of an ACL 4 months ago and has acute pivoting injury to their ACL. They've got an MRI that confirms an ACL rupture, a bone bruising pattern, no significant collateral injury, no cartilage injury, no meniscal tear. And they're told that you can manage it non-operatively, we'll start things going, we'll get you going, you'll be fine. If that patient has another pivoting injury and this time comes in with a bucket handle tear of their lateral meniscus, a chondral defect on the weight-bearing surface, lateral femoral condyle, and their ACL, then we've got a situation where a patient's likelihood of returning to sport, their likelihood of having early post-traumatic arthritis, their likelihood of a good outcome is significantly reduced. And that patient, reasonable argument for saying, well, if I'd known that or that issue was discussed with me, I may have taken a different pathway. And I think if that discussion of non-operative management is being had with the patients and documented and they're aware of that risk profile, it's entirely appropriate. But we see a lot of patients coming in now that have had non-operative management and you're repairing their lateral meniscus and you're talking to them about early post-traumatic arthritis. It's a very difficult conversation to have because they say, well, I wasn't told about that. Whose fault is it? And the first time you've seen that patient and the only care they've had is with GP or physio, the blame unfortunately sits with that primary care physician because they're the ones that made that decision. And I think that places physios in a difficult situation because if I was in that position, I don't know what I'd say to the patient. And I think that's where the education around it is huge. And I think if we have cross-pollination of ideas and cross-communication, just like this podcast, then there's always a flow of communication. And it's a case of physio. For me, for my network of physios, it's a case of a physio ringing me up saying, "What this patient? What do you think?" and I'll say, oh, well, if they're 55 and they are aware of this and this and that, document and tell them they can have they could tear their lateral meniscus, they could do all those things, go on with non-operative management. That's quite reasonable. But receive a patient 4 months after their initial instability episode, and now they've got 2 MRIs showing that they initially had an ACL rupture and now they've got a lot more. There's a gap there that needs to be filled.
Do you think that's like on, say someone does come in, is that to the physio to have that conversation? Because I imagine it would be, or whoever's managing it, I imagine it being difficult if you maybe, like, if you're not aware of the risk, you're not even able to have that conversation because you don't know what you don't know. So it's like, do you, I guess, to say that and have that stopgap in place, it would be just to get the opinion, a surgical opinion anyway, and if they don't need it, they don't need it. But I guess that would be hard. I'm imagining a young physio or whoever listening to this thinking, I don't even know that was a possibility, that they could have this meniscal post-traumatic arthritis, and then that all falls on them. Like, that would be hard.
Well, and that's I think that's probably risk, is probably something that's not articulated to younger physios, or probably more so physios away from larger centres. And I think it's the advantage of sitting here and chatting to you about it today is you get to put that information across, because I've sent it 5 times this year, and it's now early July, and I think that most orthopaedic surgeons, I mean Newcastle especially, which is obviously where I work, we're lucky enough to have a network of knee surgeons who are all like each other. We support each other. There's no backstabbing. There's no bitchiness or not. And we all seem to have, especially the younger generation, have very close ties to the physiotherapy community. We're all friends with physios. We all talk with them. We all have coffees. We all share information. I think in Newcastle we're probably a little bit luckier than a lot of situations. But if you're a physio out in the middle of Western New South Wales and you've got an uninsured patient who has limited access to specialists, understandably you want to have a crack at non-operative management. But I think I always say to physios, if you're going to treat non-operatively, explain the risks and document it in your letter so that you're aware, and send it back to the GP so the GP is aware that you've discussed those risks. And probably the biggest thing to say is, look, I've explained to the patient that there is a risk of progression of this instability episode if another episodes to occur. We've accepted those risks. We're moving forward with non-operative management, but the patient's aware. And that sounds horribly legal, but that's what it is.
Needs to be, yeah. Especially when, it's someone's the rest of their life. Like, it's so important to say you've had those conversations, I imagine. And I'm sure that, what you're documenting in your notes all the time, because they're pretty serious conversations that you are having. Yeah,
absolutely. So I attended a meeting with my indemnifier. We had Avant Insurance, who indemnifies most orthopaedic surgeons in New South Wales. They often have information evenings about consent and what that means and what the expectations are. And every time you sit down at one of those meetings, it blows your mind how much more we have to explain to our patients, how much more we've got to give. And even down to the point now where they're saying, there should be a 2 or 3 page document that you're ticking boxes of all the risks involved, and having the patients, got colleagues that the patients are aware before they come in that their conversation is being taped, so that they've actually audio file of their patient's entire consultation. Because of the risk of litigation down the track. And it's a difficult space to work in, because we're rather than being free flowing with our thoughts and the way we manage patients, sometimes we have to tend to be more defensive. But I think that's probably the nature of the world we live in at the moment, and probably has been a flow on effect from what we see in the US.
Yeah. What is the biggest risk of non-operative management, like from that you would see? Is it like post-traumatic osteoarthritis, or I guess in an isolated ACL and then also an ACL plus surrounding structures?
So the conversation I have with patients now is that the reality is human beings are just living longer. So medical technology evolves so fast, and that's our ability to keep people alive. I'll get to the point when I'm going off on a tangent, but
philosophical here.
We're living longer, and our cartilage and bones and ligaments weren't designed to live as long as we are. So the reality is that human beings' functional expectations with age are getting greater and greater, and people are less and less willing to accept pain and dysfunction moving into the later stages of their lives. So I booked a few knee replacements yesterday, and the hardest thing is figuring out when you fit someone's knee replacement between their 6-month caravan trip around Australia and then their summer in Europe, or they want to do a coastal walk or that kind of thing. So, 65, 70 years of age now is very different to what it was 20 years ago. So yes, early arthritis is a problem, but the point I'm making is the reality is most of us are going to end up with arthritis and painful knees. And if we live to 80, most of us are going to end up having to make a decision at some point as to whether we reduce our expectations to fit in with an arthritic knee or whether we have a knee replacement. Now, I guess technology might change that at some stage, but for the foreseeable future, the majority of us will end up with some form of arthroplasty if we want to maintain a pain-free and functional existence. So to that end, for non-operative management, my biggest thing is living with an unstable knee that you can't trust. And so when a patient comes in with a ruptured ACL, the first thing I say to them is, what are your functional expectations? And if they want a pain-free, functional and stable knee, the most reliable way of me achieving that for them is with an ACL reconstruction. If they're willing to accept some instability or they're willing to reduce their exposure to instability episodes, they can actually manage without an ACL. But the majority of people that are 45 and under aren't willing to change the way they live their life for a knee that there is a potential option to make it more stable for them. And that's just human nature. You ask any 30-year-old whether they're willing to give up their functional activities and manage their knee for the next half a century, and most of them say no.
Yeah.
You did just raise a question, and it's not related to ACL, but I had it twice this morning and I had it twice already this week. I just wanted to ask you one quick question around knee replacements. When people say that they have been told by other physicians they need to wait as long as they possibly can until they get a knee replacement, just hold out until you can get it, is there any truth to that because they don't last very long? Or is that
categorically false?
Okay, I thought so because I'd heard this by someone else and I was like, I keep hearing it. I need to ask someone because I obviously have no idea. I was like, I need to ask someone that actually knows what they're talking about.
And it comes down to functional expectations. So if you've got people's, as we know, and this comes to the psychology of patients, people's perception of pain differs greatly. Have patients with bone-on-bone radiographic evidence of arthritis that function beautifully, have no pain and are fine. You have a patient with a 5 by 5 millimeter grade 4 cartilage defect on the weight-bearing surface of their medial femoral condyle, and they can't walk. And so it really comes down to the patient. And to say to a patient, I can't remember when I was at registrar, people saying, oh, you should wait till you're 65. There's no evidence behind that. And the concept of a 65-year-old is different to what it was 10 years ago, and it will change again. The reality is if you're, and I'm quite brutal with patients, I say, when your knee pain is bad enough to justify me getting a power saw, cutting your leg in half in 2 places and putting metal and plastic in there, that's the time to have your knee replacement. And that's the brutal reality of it. I say to every patient, you'll hate me for a while, you'll hate your physio more, but in 85% of cases, you'll end up with a pain-free and functional knee. Is that worth it to you? And if they can cope, they'll go, look, that sounds horrible. I'm going to run with that for a while. I'll get back to you. Or they go, absolutely, I can't sleep. Because I can't sleep, I'm cranky, I'm tired, I'm fighting with my partner because of it. I can't walk properly. I can't be the person I want to be. I can't chase my kids around. And if that happens in a 50-year-old person, you replace their knee. And so I think putting a chronological a number on it is false because we know there's 80-year-olds that are fitter than 40-year-olds running around.
Yeah, definitely. You can certainly see those people that come into the clinic and they tell you their age, or you see their age, and you just look at them and you're like, how? Like, you look like, or you function like you're 20 years older than you are, and then vice versa. The alternative to that happens as well. So yeah, I feel like age is definitely just a number, hey?
It's absolutely right. And that's where you've just got to read the patient and see what they want to do. And as I said, with the advent of modern technology, most people are unwilling to accept a quality of life that could be made better with safe, reliable, reproducive elective surgery. And to say to someone, go away for 10 years and live with a painful sore knee, that is basically confining that person to 10 years of miserable pain. 10 years is a long time when you've got a sore knee. So the data for joint replacements is getting up to 30 years plus now, 20 to 30 years. And our technology is improving year by year. The quality of the polyethylene we're using is improving year by year. Our operative times are reducing. Alignment and rotation is getting better and better. And I think our appreciation of the rehabilitation process is getting better. So every step we take in surgery tends to be heading in a positive direction. So the evidence suggests, based on what's happened in the last 10 years, that longevity and reliability of joint replacements will improve with time. The other thing is, if a knee starts to wear out and the patient's 85, if it's wearing out, doesn't necessarily mean you've got to go and pull that knee replacement out and put a new one in again. At 85, that patient may be willing to reduce their functional expectations to fit in with a knee that doesn't work perfectly, and that's absolutely fine.
Yeah. I have a few questions on the mechanism of an ACL rupture. There's, again, another sort of current controversy around if dynamic knee valgus causes an ACL rupture. There was a study in 2009 and 10 that looked at video analysis for those who ruptured their ACL and those who didn't, and it wasn't entirely clear whether that mechanism sort of is true. I'm keen to hear your thoughts on that.
Yeah, so I think probably the biggest thing about all ACL mechanisms when you see these patients is that the majority of patients give you a different mechanism for every single patient you see. And trying to define it as a true valgus force, a true varus force, a true rotational force, a true hyperextensile force is so hard to do, because a lot of patients will say, like the classic thing we say is a non-contact pivoting injury. And that's such a nebulous statement. Then you hear, a winger who's tearing down the touchline and gets tapped on the side of their calf by an opposition player. And that's enough just to alter their center of rotation, to change the load through their knee, to result in a pivoting force, and all of a sudden they drop into valgus, rip their MCL off, cause a buccal tendon to tear their meniscus and bust their ACL. So I think it's, from a study point of view, we can test mechanisms of rupture, but in reality, in practical purposes, we have patients coming in for everything from stepping off a gutter to being tackled or being rolled on in the bottom of a scrum, and all those mechanisms rupture an ACL. And the only real idea we have of mechanism is looking at the injury pattern on the MRI and getting an idea of which structures are damaged and where they're damaged, and I guess where the swelling and pain is as well. A lot of patients now come in with a video. The high-level players come in with televised videos, and they'll scroll through their video and go, this is where I ruptured my ACL, or this is where I dislocated my shoulder. And we can slow it right down frame by frame and actually pick the moment where the ACL ruptures, which is something we've never been able to do before.
Does it change much of what you do or recommend if you're able to see that video? Like, if you see it, has there been a case where you saw like, oh, that actually does influence what I would do clinically? Like, how much does that matter if it's this kind of unpredictable way that it happened, and you see like, oh, okay, that would make something different? Has that ever happened? Can it happen?
To be honest, not really. It's more fascinating to see it, because a lot of patients come in and go, I just stepped awkwardly and it popped, and that's what you hear probably 8 times out of 10. When you see the mechanism, what I often look for, I mean, the first thing is if they're playing collision sport, you immediately know that the likelihood of the severity of trauma is generally a bit higher. I'm often interested to see what happens whether they're able to get up afterwards and walk, whether they're able to weight bear. And the majority of ACLs, ironically, can weight bear. Some of them get up and start running again and keep playing, and then come off 5 minutes later when their knee goes again. But I think most of the players that come in with a video are more interested in showing you how it happened. But we didn't have that luxury 10 years ago, so it's more out of interest than anything else. It doesn't really change what we do. I'm more guided by the MRI, and with the way I do an ACL reconstruction, it also comes down to the kind of sport they play and what they want to achieve, whether they're planning on return to collision sport, whether they're planning on dropping a few grades, whether they're planning on giving up sport altogether. Yeah, they're more things that drive what kind of surgery I do.
From like when they come in with like a video, my thoughts are that it happens in like a 400th of a second, like so quickly. And is it just that unique set of circumstances where they've ruptured it? Like, is that not something they've gone into many times before, and for some reason under this unique set of circumstances it's ruptured? And then to add to that, like, is there any way that we can actually prevent them if that's the case?
Yeah.
That's what
So
my thoughts are.
I think it comes down to that discussion about reducing variables. So if you've got a patient or a player who understands their role in the game, is aware what is required of their body, has trained appropriately, has the appropriate conditioning to minimize risk, and then plays in a way that avoids injury, which sounds ridiculous, but for example, a player in the outside backs is less likely to get a collision injury than someone who's around a scrum base or in the middle of a scrum. I think it's difficult to say. I think the way we're heading with high level athletes at the moment, that the way they're conditioned and prepared for sport is so carefully orchestrated and so carefully managed at the moment that the likelihood of the injury is significantly lower than what it was many years ago. But I think ultimately it doesn't matter what you do. If there's a specific set of circumstances, your ACL is going to rupture. And then what I explain to patients is that you can train and return from surgery and reduce your chance of injury as much as you can. You can control your little environment, but as soon as you step onto a field, there's a set of environmental variables that you can't control. And once you step onto that field, you're at the beck and call of whoever you're playing against. With my high level surfers, you say to them, you can train as much as you want, but when you go into the environment of the ocean, there's variables that you will never have seen before that you can't control, and it's anyone's guess what's going to happen in that situation. So I tend to believe that we can optimize patients to reduce the chance of an injury or reduce the chance of an ACL, but at the end of the day, those injuries will occur because we can't account for every variable.
Yeah.
Are there any kind of like risk factors that you see, like an archetype of person that is more likely to have these? I guess sports where there's change of direction or sports where there's uncertainty. I guess kind of what you said.
So usually young patients, high level, so elite level players, athletes, people with hyperextensible limbs, so limb laxity. Often the biggest risk I find are young teenagers that are on the cusp of elite sport, because there's pressure from numerous variables. So it's not just a kid going to play on a weekend. It's involved parents, it's coaches, it's talent scouts, it's players above them, players below them. And when you put that heady mix of a number of people into an athlete who is not probably mature enough to appreciate the consequences of what they're doing, that's probably the biggest challenge for us. And then when they come in with an injury, managing their return to sport and managing expectations, not only of the patient, but of the patient's family and everyone else involved, it's really, really difficult. And as physios, you probably see that as well. You have the parents that come in and their kid is going to be the next Socceroo or the next Wallaby or the next, and we know that it doesn't matter what you do for some of those kids, they're never going to quite reach the heady expectations that every single part of their team expects of them. And that can be devastating for a 14 or 15-year-old kid. Yeah.
What time frame do you see people generally get back post-surgery, and how much does that change depending on the injury? Like, say for just a general sport, not at an elite level, but just general sport.
Yeah, so I usually say 9 to 12 months post ACL surgery, and I know that we've obviously got temporal or time-based returns to sport, then we have functional retirement. So if you look at sort of Mick Hughes and Randall Cooper's ACL rehab protocols, they're more, I guess, outcome-driven ones. And that's fantastic in elite sport. The challenge for us in, say, our workers' compensation population or our people who have to work as a plumber or those kind of things, people need timeframes, because if I do a rugby player who also works as a plumber, their boss wants to know when they're going to be back on the tools. And so again, you've got to reduce variables and be able to say to that patient, well, I think at 8 to 12 weeks post-surgery, you'll be moving around, be able to go up and down a ladder. And as long as you've got quads controlled and you're doing well, you can get back to that kind of work. You'll probably have your strength back at 6 months. You'll probably get more your sport specific and pivoting, and I guess running agility stuff will happen between 6 to 9 months, and return sport will happen 9 to 12 months. That's what I usually say to patients, and I always overestimate the time frame that I expect they're going to be back to sport, because the worst thing you can do is underestimate that time frame and have them going back to sport undercooked. The other thing I'll always do is keep a very close relationship with my physiotherapist. So most of the physios that I work with will have a mobile number. They'll call me anytime, night or day. They'll text me. And as you say to all those physios, if you get a text about a patient with a concern, you can put out that fire at time 0 rather than 6 weeks down the track finding out about it. And then it's not the physio's fault or the patient's fault. It's the surgeon's fault for not actually being available. And so I guess the model I designed for myself when I came back from fellowship, which is based on what we did in Europe, was that we were all a multidisciplinary team and we were all just cogs in a wheel, but no person's role is any more important than the others. And the amount of times a physio has called me and averted a disaster is just innumerable. It's incredible how many times you guys pick up things that we don't see, because we see a patient for 10, 15 minutes and we think everything's great, and the patient tells us what we want to hear sometimes. Whereas you guys spend a lot of time with patients, you build relationships with them, you understand what their stresses are, what their concerns are. They might have had a bad day at work, they might have had a breakup, they might have been sick, and we don't pick that up in the course of our post-op care. And so I explain to patients that physios are almost like your ears on the ground, and that we're all part of a big team. We all work together. And that, for me, has worked extremely well in terms of ensuring the outcomes from the patients are as good as I can make them.
Yeah. It all comes back to that shared sort of decision-making. And
it's the days are gone of surgeons being the gatekeepers and living in their glass castles. It's changed, and any specialist who thinks that they can do that is not going to be a successful or well-liked surgeon, especially in this community.
What would you say? And I'm in the clear here because I'm a podiatrist, so I don't ever see any ACLs, and if I am, they're straight out the door to go and see physio orthopedics. But what would your, I guess, from what you just said, as a young clinician listening to this who hasn't seen many ACLs, like what advice, I guess, would you give them? And I guess it's